Well, hello everybody. So welcome back to our next session, and the rest of this afternoon is what we're calling sort of scenario planning, and it's really for us to dig deeper in terms of, okay, now that we say we're going to have a focus around public health, what are some ways that we can structure the sets of problems that are underneath that space? And if you're in the audience, we readily encourage you to post some of your questions, and especially more in terms of suggestions of where you think we can help, kind of dig deeper into what are some problems that we can tackle as part of the hackathon underneath the public health arena. So maybe before we get there, I'd like to, of course, introduce Esteban Gershanik, who is a physician at Brigham Women's Hospital and at Harvard Medical School. Also used to be with the Louisiana Office of Public Health as well, and has deep background in data science and informatics. Esteban, maybe you can kick us off on, especially if we have new people in the audience today compared to yesterday, but how do we contextualize, or what's the framework of public health, and how do you define that in this context?
Yeah, Freddie, thanks for the introduction, and great job by you and Angel and everyone getting this together. First and foremost, I usually introduce myself as your typical American Argentine Jewish kid who was born in Shreveport, Louisiana, grew up in New Orleans, minored in African studies, and my best friend is a Pakistani Muslim who I hang out with. So I think one of the items that one of my colleagues always said was true innovation is looking at a problem through the lens of as many people as you can and getting the right people around the table to look at that. And when it comes to public health, my background is a physician in medicine and pediatrics with a background in management, public health, and informatics. And when it comes to public health, it's looking at the problem of one's health through the lens of everything that encompasses that. Yesterday we discussed, or I tried to present the broad overview of what public health is, the disparities in public health, and how it encompasses everything from one's individual health to the construct, the social construct of race, the dynamic of the other social determinants of health, for example, the area that one lives in, the job that they have, the education that may be within their system, the access that they have to clean water, the lead in their area. All these dynamics compose of what overall and universally is public health. So it's not just one's individual health is you go to the doctor, that's what it is. It's the construct of all the social determinants of health that take part in how an individual and a population encompasses sort of what they're about and how their health is.
And maybe also since we're on the topic of helping sort of define the terminology and the framework and structure, could you say what is population health versus public health?
Yeah, and so, public health, we often say, is the science or the art of preventing disease, prolonging life, promoting health through the organized efforts and informed choices of society, organizations, public and private communities and individuals. So it's an all-encompassing of all those dynamics. And then the way I look at population health versus, let's say, individual health is the idea of looking at a population as a whole and understanding their health versus others. And so when we do that, we see a lot of disparities in care and health inequities in the data and in the literature around certain aspects of, as we discussed today, African American population, also Latino population, Latinx population, Native American population. All these populations, also based on the geography of where one lives, determines their healthcare outcome. And so all those ideas are ideas of overall public health, population health, and then individual health, and trying to figure out how we can sort of approach this to ensure an level playing field and that we address all these issues all at once.
And, sort of thinking about, we've talked a lot about sort of the linkages from, the problem sourcing side and then the implementation side in terms of who we engage as part of the stakeholders. But what does implementation of a public health solution look like?
Yeah, that's a great question. So the way that I often approach it is multiple. So I try to think first, what is the current data? having a background in data, I always like making sure that whenever I make my argument, I have data to support it. And so you want to first frame a question that has different sets of questions along with it, right? Are you talking the geography of where one lives? Are you talking their socioeconomic status? Are you talking their race? Are you talking their employment? Are you talking access to healthcare, access to broadband, things like that? That's a broad, you can ask a question that can cover each one of those subsets into one whole question into the delivery of that healthcare. And then once you break that down and you discern each of those subsets, what is the data around some of those subsets? And often what you can find, and there's a lot of healthcare data resources and data resources that are accessible, whether you go on the various federal websites or other websites that you can even Google and find, is that each of them will have data on each one of those individual data sets. And then you have to say, well, when is this data from? And so some of this data is from like 5 years ago. Well, how do I use data from 5 years ago to data that's today? And then the question I often ask around that is, why is there a difference in data? And why does the data not have what I need? Because some of the data sets don't have what we need. And I think I explained yesterday, when I got to Louisiana as their CIO and their health informatics director, I know that the community there, since I grew up there, has a large Latino, specifically Honduran and Vietnamese population. And I couldn't get data from this one data set that had information on the Latino population or Vietnamese population. Well, if I am going to collect data to answer a question of my community and different populations, how am I then going to implement if I don't have the data and don't know how to communicate into that, to that population properly and engage people from that population? And that goes back again, when it comes to the hackathon, ideas of getting the right people around the table, and the idea of innovation is having all those questions lined up, all those right people around the table, and talking to everyone and saying, all right, how do we go from the idea of what is the data, what is the question, what is the data, what are the data sources, how accurate are they, what are the policies around them, and then once you see those gaps, then deciding how we can implement it and how do we engage the community from the beginning to the end to ensure success.
That's great to hear. Because I think that's one of the most important things is that if you don't take into account the potential stakeholders that are at the end of the pipeline that are going to be helping as part of the execution of the solution or the idea from, and you don't think about them from the very beginning, I always say it's sort of, by the time you get to that stage and engage with them, you'll realize that there's 10 other things you should have thought about to incorporate into your solution. And so you may have taken 2 steps forward, but then you're taking a step back each time you do that process. And so elongates in our opinion, the innovation process and getting to that implementation. And so, thinking under the umbrella of public health, what are the existing structures that further breaks down areas of public health? Is it usually done is it on sociodemographics level? Is it on a disease level? Is there, essentially, what are some ways that people can think about that framework or structure of how public health is being talked about and defined and addressed?
Yeah, so traditionally, I would say it's looked at through the disease level and the population level. Now, each state has different information, though there are some national guidelines. And also when you want more specific information, usually under an entire Department of Health, whether it's Massachusetts, Louisiana, or anywhere across the country, there's different subsets, and they're basically organized the same way. There's an Office of Public Health that has everything from maternal, infectious disease, some of those reportable diseases, vital statistics. Often what people try to collect is seeing what the cause of death is, not understanding that some states have various coroners or medical examiners that either have a PhD or just maybe the cousin of the local representative that has that role. And so sometimes they don't have the resources to properly collect the data. So traditionally, I would say, one, it's by disease, because that's how it was traditionally created. 2, there's been a push in recent years around social determinants of health. So that's been a bigger push nowadays that people are trying to understand. And then 3, the socioeconomic component you can access through other resources. And I think the key is to break down those traditional silos and put them together to answer those more complex questions.
You mentioned social determinants of health, and I think some of us know what that means. But could you expand on the breadth of what social determinants of health really covers?
Yeah, and I think yesterday what I showed is like all the components that contribute to the overall health of an individual, which includes the neighborhood and environment they live in. There's one county in Louisiana called Cancer Alley. They are right next to all the petroleum plants that have caused cancer. And anyone who's seen like Aaron Brockovich knows that there's areas around the country, whether California or anywhere else, where there's areas where, one, you are prone to cancer just based on your zip code. Two, there's folks like in Flint, Michigan, where the water that you're getting can kill you, or has many places across the entire country. There's areas that have high lead levels. So just based on where you live can by itself be a social determinant of health. And as I demonstrated yesterday in Massachusetts, in Boston proper, your zip code just miles away can cause a difference of your average life by 32 years. In Louisiana, it's up to 25 years just miles away. Then there's access to health and healthcare. Some areas, whether it's rural parts of America or other zip codes, don't have hospitals nearby. They don't have primary care. And again, they don't have access to broadband or virtual care, which has become more and more popular during these COVID times. There's also areas that don't have jobs, don't have unemployment during these COVID times. Usually the most vulnerable of people are the ones that are essential employees going in and putting their lives at risk, but also are the ones that are most prone to not having a job and being left off and not having the income to help out, which contributes to your health. You also may not have the educational resources. And then the entire social and community context. So, I mean, all those things are key attributes that we say are aspects of your social determinants of health and are key components to one's health. Instead of you go to the hospital, you're sick, your body has something. No, all these things and what the literature has said and what some of the hypotheses were in the past were all these stressors. The body it's like anything in life. You put stress, there's a response to it. The more stress you have, whether it's just with a disease or all these other social determinants of health, the other components, it's going to affect your health. And so that's what I mean when I say social determinants of health, public health, and health as a whole for both people and populations.
I think let's start digging deeper in terms of the different lenses you can use. We talked about social determinants of health, we talked about geography, we talked about disease. You can even look at it from sort of preventative versus more sort of treatment and that reactive process. Within the disease space, where do you think, especially in the context of systemic racism, where do you feel like disease spaces are much more afflicted or where the gap is wider in terms of the role of systemic racism in that space?
Yeah, so first I'd say it depends on what data is out there in what field, right? So what's gotten a lot of attention recently has been COVID, but even before COVID, there's aspects around how Black women are up to four times increased morbidity and mortality when it comes to delivering a baby. That's crazy. And people then asked, I think yesterday, about, well, does that matter socioeconomically? No. Often there's some studies that show higher socioeconomic Black women have higher incidences. So it doesn't matter. Sometimes that can increase stresses. And then there's other aspects, in the recent incidences that we've seen this year, whether George Floyd or everything else that we see almost on a daily basis now via video, there's components of where we see, and this is also part of public health, there's a violence repository, there's gun repositories, depending on the state, how they collect it, and the CDC. And then also there's violence between police and the community. And so when you have twice the incidence of death by police being twice as much for Black men versus white men, that's another concept of like what people have been discussing and how do we better understand it. So when it comes to, again, the structural racism component, race is a social construct. I think where you have to answer the question is where your interest is in the public health space. Some people may have an interest towards infant morbidity and mortality. That's a concept of also thinking about the WIC programs or education around breastfeeding and other components of that. Also around, there's a component around Hep B, Hep C, HIV, and substance use disorder. All these are different components. So I think it's one component of having the question that you want to answer, scoping that out properly and deciding on that. And then there's also the concept that I sort of helped push a little bit a couple of years ago that we saw with substance use disorder, and that more and more people were injecting needles. And so you saw an increase of Hep C during a time of an increase of substance use disorder. And there's a concept called syndemic, which is the interaction of two or more coexisting diseases and the resultant of the burden of disease, which means based on health inequities and structural health inequities as a whole, whether it's poverty, stress, structural violence, all these things increase the burden of not just one disease, but multiple diseases, one on top of the other.
No, it's great to hear. I think one of the other questions I wanted to ask you was in regards to sort of thinking about these other components that aren't necessarily health direct, right, is what I tend to at least cast it as. It's not like the actual healthcare itself or the disease itself, but there are a lot of things that either lead to higher propensity of those diseases to start developing or to. So how do we address those issues under the context of public health? Where is that boundary where public health departments now start taking that into account, whether that's housing or education or socioeconomics? There's got to be a place where you put that threshold of.
Well, that goes back to collaboration, right? So, Freddie, your physician, right? Just take into account the idea. Let's put this context for those who are doctors on the call, and think about how we traditionally were trained to take a history and what data comes in. Imagine, and this is some of the thoughts that are happening in the broader market, if our electronic health record incorporated the idea of public health information. So we now have the prescription drug monitoring program integrated in many of our hospital systems. Imagine if you had a patient come in from a high density area of substance use disorder or of certain public health issues. How would that frame your questioning? How would that frame your further discussion of what their history is? Traditionally, we write down for our social history, what? Do they smoke? Do they drink? Do they do illicit? Are they married or single? What's their job? Perhaps what their education is. Are those really the right questions? Should we really be changing the way that we train physicians to ask broader social determinants of health instead of those things that often when you look at the file can sometimes be empty? So I think the key to answering those questions are, what is the question? How do we break down those walls? And how do we collaborate better? And the goal of interoperability, which is standards that have been pushed forth on the federal level, is how do we break down all these barriers and make sure that we can do this as a collective whole? Because ultimately, all these things contribute to people's daily lives. So just to give you just a different perspective as to like how you see things, because it was interesting when I went to the public health space and the Department of Health, I saw things from a different side than I did from healthcare delivery. And I recognized that my clinical insight was something they didn't have either. So it's one of those things where those walls have to be broken down so that we better impact our communities as a whole.
I think that's a great response. And so the last question I'll ask has been, public health is on a broader scale, right, affecting large groups of people. But then we also talked about how your zip code can define what your public health is. I guess, do you see at a point, is there a certain number of people or what's the scope of people that need to be focused on developing a solution towards that would define it as being within the public health context?
Yeah, I mean, I want to make sure I don't answer your question incorrectly and that I understand it properly. Because I think, one, it's the system as a whole, right? So systemic racism as a whole is a structure. And if we're going to, healthcare delivery has traditionally been structured based on a hierarchy. We talked about also proper representation. We do a extremely poor job of making sure that the people taking care of a population are like the population. And we do a poor job of engaging communities into their healthcare as a whole. So we have to stop breaking down this very hierarchical way and engage people from those zip codes to know what's going on and integrate ourselves in those zip codes as well. During COVID, one of the nice things that we were able to do in New Orleans, thanks to the health commissioner there, Jenna Begnaud, and other folks on the state level, is we recognized when we opened I was able to open the first federally designated drive-through testing site for the country down there, where we had a high prevalence of morbidity and mortality, and where we have a large population of Black and brown people. And so it's a matter of, we at first opened up a drive-through testing site. Well, who came through? Well, not everyone can come through during the hours of 7 to 5. Not everyone feels comfortable when you have National Guard there if they may not be a legal citizen of this country. So you're putting up barriers. And what we saw then was, initially, while we were able to provide tests to a community that didn't have it, we then recognized we need to be mobile. So we then went to communities that had those zip codes of higher prevalence and went to the community instead of having the community come to us. And the thing we have to take into account is many people have essential jobs where they're working 7 to 7. So let's go outside the context of traditional 7 to 7 or 9 to 5 and make sure that we do what the community needs and be more interactive in that.
So thank you so much, Esteban, for your time today. And maybe if you can stay on a little bit and help answer some of the Q&A kind of offline, that would be great.